Dr. Sittig is going to talk about acute burn resuscitation today. He's one of our core faculty department of surgery. He's a burn surgeon, multiple hats he wears. Today we're going to talk about burn.
Yeah. Here's the deal, okay? We're going to talk more about electrical injuries and the electrocution components, only because it is a small but specific caveat of burn care. But I'd like to use the opportunity to basically educate the group on flame burns and everything else, because many of the electrical burns that we're going to see are billed in the transfer as an electrocution injury, where in truth be told, it was a major arc flash fire explosion that caused a large surface area burn with actual no electrical conduction through the body, causing them to have a problem. And then you have those that are the combination of the two. They get the flash, they get electrocuted, and there's a blowout injury somewhere else as well. So it's right. This is open to you. Please stop me at any point in time that you have a question, you want more details about things or whatever, because I'm going to blow through it. I know it's Friday and everybody's got things to do, but let's make this interactive. So 1 million injuries a year, and actually we feel that the numbers are probably underreported, because those aren't the people that went to primary care docs and had burn injuries or even minor electrical injuries. That children that bit an extension cord, that had a lip burn, may have been seen by the dentist or oral maxillofacial surgeon, and a lot of times that data is not collected. So we really think that it is grossly underreported. But 750 deaths doesn't sound like a lot, which is why we're thinking from a underreporting standpoint, it's definitely there. The etiology, these are the numbers that we see at our center or have seen for decades, and it really hasn't changed much. And it pretty much correlates with the National Burn Registry as well. And you can see that electrical injuries only make up for 5%, and that's probably on the high side, because that includes the electrocution flashes that the electrician working at the box has a quick flash burn back that burns their face, neck, chest, torso, but it's like a bad sunburn, and we treat them, see them, and most of the time are able to treat them as an outpatient. That's still an electrical burn, but it doesn't really have the electrocution component associated with it. By far the most, and these are the ones that end up deep to get admitted flame, those skull burns make up for the overall marked number one cause of burn. So if you have an exam anywhere and you want to find out the number one etiology of burn wounds, it's a scald injury. And in children, what's it from? Ramen noodles. So I saw 7 this month. And right after the Highland Parade runs and they throw them off the floats, the numbers go markedly up. It's just amazing. And that's across the country. Ramen noodles. There's been more. It's cheap. It's cheap, so it happens. I like to put this up from the anatomy standpoint, because everybody gets confused, as I did when I was in these seats at a younger age too. How in the world can you burn your entire epidermis and yet have it call it a second-degree burn that's going to regenerate skin? But you got epidermis and dermis, right? Is the dermis going to generate epidermis? No. But you see, around the hair shaft, and then that's supposed to be a little sweat gland, sebaceous gland, there are epidermal skin elements that traverse down every skin appendage. And so that's why we can have a very, very deep second-degree burn that burns off all the superficial cornified epidermis, most of the dermis, and even deep dermis, yet they regenerate and they heal. Now, it may take 6 or 8 weeks before you begin to see skin elements coming up, and that's why surgically we treat most deep second-degree burns as if it's a full-thickness injury, because by the time they get wound closure and coverage, most of the time the skin has got more elements of scar than skin, and they're better served with a skin graft. Everybody clear on that? So, first, second, and third, a lot of times are referred to as dermal, deep dermal, and full thickness. Full thickness means you're to the fat. There's no way that there's any skin elements left to generate any skin. What's fourth degree? To the bone. All right. First, second, third, we've kind of talked about it. And the interesting thing is on the third degree, that burn may be white, pliable, black, charred, leathery, or bright red. And you will see a bright red cherry burn on an extremity, and it doesn't blanch, and it's like, what is that? It's red blood cells that have been tattooed from the heat acutely in that dermis. So it looks like a bright red, beautiful tattoo. Trouble is, the next morning it's darker red, and then by the third day it's black. So don't be confused. Everybody wants to look at the color and go, oh, it's red, so it's got to be a second-degree burn. You've got to be able to touch it, prove that it blanches, and then make an assessment at that point in time. And the reason for denoting and knowing how to separate out first-degree burns from second and third is why. Resuscitation fluids are calculated based on what? Body surface area injured with a second and third degree burn. So you can go outside, stay outside all day, have a first degree or a very, very superficial second degree burn. And if you come to the burn center, we're going to give you liters and liters of lactated ringers. I'm going to give you some pain medicine and scold you, send you out, tell you to go home. Because it's not a systemic injury at that point in time. But deep second or even mid-level second and third degree burns need to be calculated, and that's how we calculate resuscitation fluids. All right, estimating the body surface area. Everybody know the old rule of nines? It's still the same. Learn it. Children, it's completely different, though, because, and I'll show you the Lund and Browder chart, and it becomes important. And the reason these are important is, with a child, a burn of 15% or greater, that child needs IV resuscitated fluids. An adult, 20%. So a 19% second-degree burn on an adult, as long as they're not nauseated and I think they can drink and take pain medication, I can probably follow them as an outpatient to avoid exposing them to nosocomial-acquired, really, really bad bacteria and pathogens that live in a hospital, as opposed to showering and taking care of their own wounds in their own home and their environment that they're used to living in. Okay? So that's why we want to be able to calculate it out. And the quick and dirty is your hand is 1% of your total body surface area. So when you got a little splash burn that's scattered everywhere, just use your hand, 1, 2, 3, 4, and everybody's in. You're saying, oh, this is 11% burn. Everybody's going, how did they do that? Well, as opposed to it's 10% of the 13% torso and 8% of the left upper arm. And by the time you get all those percents out there, we get calls that it's a 75% burn, and it gets here and it's 11%, and we're sending them home. So I'm trying to educate you so when you go out in the community or private sector and you're called to see someone, you can accurately calculate it. You can't see this, but in a 1-year-old child, the head is 19%. Not 9. So if a child's looking up on the counter in a kitchen and pulls a big pot down and it gets their scalp and their entire face and head, that's already 19%. So that child will need resuscitated fluids and need to be admitted and watched, okay? Whereas with an adult, if you're thinking, oh, it's 9%, and it just got a little bit of the scalp and came down the face, that might be 3%. So that's the important issue there. And you can see the little diagram. It's face, neck, anterior torso, posterior torso, upper arm, lower arm, hands, buttocks, posterior thighs, lower extremities, and feet. And that's how we're able to come up with a closer calculation of total body surface area injured. Stop the burning process. And this is most important with chemicals and with electrocution injuries. They're going to have an entrance point somewhere, and there's an exit point somewhere else. I got a slide later showing a foot that the man didn't even want to see. He's like, I burned my hands. It's like, I understand, but we got to look at everything. Didn't want to take off his boots for whatever reason. And he had electrocution blowouts in his feet, in the bottom of his feet, that he didn't feel. They didn't hurt, so that he didn't even know the injury was there. So strip them, get all the clothes off, and more importantly, get rings off. Because if in the area of burn, they're definitely going to swell. But in a burn bigger than 20-25% that's getting resuscitated fluid, the whole body's going to swell. So you want to get the rings and jewelry off of the unburned extremity as well. How do we calculate burn severity? Not very well, I'll be honest with you. There was originally a Z-score, now there's a T-score. There's all the other scores out, and for the most part, they calculate it as the age of the patient plus the body surface area injured. Well, right now, the young lady that is married to the med student, she's 25 years old. She had 95% burn, and she's doing well. So, I mean, so the burn severity, mortality predictor formulas in that we have out there are not ideal. And they just don't work. And that's because burns are complex, and more importantly, if there's inhalation injury and pneumonia, a small burn has a higher mortality rate than a big burn with no inhalation. Electrocution injuries are very, very difficult to manage because you just don't quite know what's been damaged from the entrance point to the exit point. And so they may have cardiac issues, they're definitely going to have renal issues, and they're going to have deep-seated infections where neuromuscular damage has occurred with normal appearing skin and that on top that people are missing. So, in the acute phase in the trauma bay or anywhere else, it's just like anything else. Your ABCs, airway, breathing, circulation, and then exposure, and then redo it all over again. I mean, we get calls all the time that they don't have blood pressure. Well, their upper arms are burned. It's like, put a blood pressure cuff on it. We need to know their blood pressure. How in the world can you treat someone unless you know their blood pressure? IVs, start them through a burned extremity. You got to get fluids in to start. And not everybody who's been exposed to an outdoor explosion with singed nasal hair needs to be intubated. Okay? You have to be in a closed, confined space to have an inhalation injury. You may have had exposure, but you won't have had an injury. So not everybody needs an endotracheal tube and fly here with a helicopter when they lit a brush pile outside and there was a quick whoosh. Very complex formula. Shrine had their own, Galveston had their own, Cincinnati had their own. At one time I looked and merged all of them, did a complete literature search, put them all out there, and basically came back with Parkland formula. Continue to this day, as of the meetings last month, is the gold standard. And it's still Ringer's lactate. They've tried Normasol, Plasmolite. Every time somebody comes out with a new balanced solution, there's a big attempt to try to do it. Normal saline has way too much sodium chloride in it for a major burn to get that much sodium chloride during the resuscitated phase. Ringer's lactate is still the way to do it. Now, this is an estimation. It's a starting point, okay? So 4 cc's per kilo per percent body surface area burn times the weight, okay? So you have a 100 kilogram individual with a 40% burn. What's the calculated fluid? Estimated for the first 24 hours. 4 times 40 is 160 times 100 kilos, 16,000. So that person needs 16 liters of fluid estimated in the first 24 hours. So when Dr. Abdullah from Tallulah calls you and tells you that, and you tell them, start them at 1,000 cc's an hour because I want to give half of that 16,000, which is 8,000 liters in the first 8 hours post-burn, they go, he has a history of congestive heart failure. And I said, I understand that, but he will not have any fluid in his veins shortly, and he'll be pre-renal, and that's worse than having too much fluid. We'll worry about that later. Okay. 3 hours later, after arranging a transfer and that, they get to you, and they've had fluid running at 100 cc's per hour, and they're in acute kidney injury already, hypotensive, and we're behind the 8 ball. So calculate the fluid, and the first initial half of it goes in 8 hours. And that's why you want to be sure you're accurate with calculating second and third degree burns, because if you don't calculate it right, you can grossly under-resuscitate, or more importantly, you can grossly over-resuscitate. And with that said, Foleys go in and you manage and monitor the urine output every hour. So if you're running them at 1 liter an hour, how much urine do we want them to make per hour? For any individual patient. You admit anybody. You're writing, orders for the nurses to call you if urine output less than such and such. What's that based upon? Pardon? Basically a half a cc per kg for an adult per hour. So if a 100 kilogram man comes in, as long as they're making 50 cc's of urine an hour, that should be enough fluid running through the kidneys in order to excrete metabolites that need to be excreted. We always want it a little bit higher, but that's what you're shooting for. Children need 1 cc per kg because they need more volume in order to adequately excrete the metabolites from their kidneys. Now, children, I should have called it the modified LSU as opposed to Brook because it's really not Brooks. What I figured out a long time ago is if I take the Parkland formula, meaning 4 cc's per kg per body surface area burn, but I drop it down by 3, that'll give me the Ringer's lactate amount of concentrated resuscitated fluid to give a child, but use D5 half normal for maintenance fluids. So you calculate if this baby had a gastroenteritis, viral illness, and they're throwing up, what would their maintenance IV fluid rate be with the dextrose-containing solution? So that gets started. And if it's 42 cc's an hour, you start them at 42 cc's an hour there, and if their resuscitated fluid is 80 cc's an hour of Ringers, then they got 2 IV fluids running, urine output's being watched, and if the urine output is above 1 cc per kg, then I decrease the resuscitated fluids every other hour by 25% until I get to a steady state. And at the end of 24 hours, they will typically be off of their resuscitated fluids and they're on their maintenance fluid. Does that make sense? And why do we do that? Because if I use D5 Ringer's lactate, I'm giving them way too much dextrose and I'm going to make them hyperglycemic. And if I use just Ringer's lactate in a child, they're going to get hypoglycemic. So that's the reason for the 2 IV fluids. Okay? And that's, yeah.
On the kids, don't we give them dextrose also?
The D5 half, the maintenance fluid is their dextrose. So that's where they're getting the necessary glucose carbohydrates that they need to keep from getting hypoglycemic. So, flash burn. Was that child needed to be intubated? Stick your tongue out. Oh, there's a little bit of char there. Oh my God. They're going to lose their airway. We've got to intubate them before we send them. What was the mechanism of injury? Outdoor. Lighting a trash barrel. Now, if he's smoking and he's got home O2 on, then the flames may have actually gone up into the nostrils or the oral pharynx or whatever. That person needs a complete exam and might need to be intubated, but this one just doesn't. So this kid came over, helicopter, a $30,000 helicopter ride with an ET tube to be extubated and then wait for family to show up and then send them home the next day. Second-degree burns, just blisters everywhere. You see the red color? That's a deeper second-degree burn. Blisters, what does a blister indicate? Second-degree burn. Do we need to debride those blisters? I don't, unless, see the nasty fingernails on this one? I'm worried that they've got so much gross discolonization on them that they probably aren't going to clean and take care of this to where I may not completely unroof them, but I'll make little snips to let the blister fluid out so that they're easier to manage and take care of. But the blisters are Mother Nature's surgical bandage. It's covering that wound better than we can put anything on it. And it prevents desiccation and pain. Blisters everywhere. Now, African American child with red discoloration that's not weeping, this is the tattooing effect that I was talking about, red blood cells in the skin. So all the red cells in that skin now have been damaged. They're discoloring the skin, and so you can count the next day on that child being markedly anemic because those red cells are no longer in the body circulation. They're taken out. And then the red cells in the circulation close to that were injured by the heat are going to be filtered out by the spleen. Flame burn, and they're never the same everywhere. So you got superficial second, and third, all in one location. This was from a hot radiator burn. What does the cap say on the radiator? Don't open while hot. No mechanics in here? Oh, that's right, this is med school. Flame burns. Remember I said on the slide, burns can be any color. So this one's absolutely white, deep eschar, translucent around the knee, because the skin's been burned to the point that it's transparent. You can look, and if you saw this slide blown up, it would be a paraffin-looking, clear, translucent fat with thrombosed veins all visible in it. Skull bathtub burn. Deep third-degree burns from tar. This is the color slide that I like to show you once again. Thrombosed vein, all the different colors. Bright red, and then the end of the toe, because basically all of the red cells are drying, dying, desiccating, and it's changing from the red to the black color. Escharotomies through it with the edema, done at bedside. Fingers or tips are obviously burnt, and you're going to end up with amputations there, no matter what you do. Hot tar, how you can get that off in the trauma bay? Call the burn service. What do we do? Soap and water are not going to work, so it's mineral oil. So an oil petroleum-based emulsion. I have an old colleague of mine that actually would go, he'd send down to the cafeteria and get a gallon of mayonnaise and start putting mayonnaise on them, because basically the oils in mayonnaise will slowly take off layers. And I'm like, even though that makes perfect sense, I would venture to say in a litigation standpoint, if you were getting a jar of mayonnaise and putting it on a face, it would be difficult. So it's just one layer at a time, and you'll see the black gloves, black everything, where we're just slowly just applying and wiping, applying and wiping, applying and wiping in order to get it off, because you can't really assess the wounds. Bathtub scald, so actually get the history, look at the physical exam, and then decide. Muffler burns, y'all see those on the trauma service where they crash their motorcycle and the motorcycle muffler sitting on top of them and they can't get it off fast enough. And electrocution injuries will look very much like that, many times in the entrance point, and then the blowout will have the classic blowout. Electrical burns. Who's more apt to die from an electrocution injury? Small household, accident. And that's where I think everybody gets confused. Household current, 110, alternating current versus a direct current. If you get stuck on it, it's going to kill you. Whereas the bigger the voltage criteria, it will typically blow you off of it. So that if you don't have a cardiac abnormality to start with, you're not going to develop one. Okay?
So you're saying 110, you'd be more likely to die?
There's actually more mortality associated with home people doing things with their plugs, changing their plugs out with 110 voltage coming to them without throwing their breakers off.
I just thought it was just they were more commonly messed with. They don't think the 220 is intimidating.
Well, the 220s will blow you away, but if you actually catch that 220 and you're hanging on to it and there's no one around, that's going to kill you. What I'm getting at is the 8700 or 8800 volts that are coming in through the uninsulated lines into our homes. Typically they lose body parts, but it doesn't kill them. They don't have cardiac abnormalities from that. How many volts is a lightning bolt? Starts at 1 million, usually 1 million to 2 million volts. I don't know how they figured that out, but I've read it several times. This is a poor individual who basically was he was a plumber, working on top of a residential building, putting in copper pipes to go in. And his copper pipe came into contact with the 88,000 volt main line coming into the area. And unfortunately for him, there's a twin hand that looked just like this because he was holding it with both hands. And to make matters worse, he happened to be up on a ladder and he had a hard hat. So the hard hat actually reverberated and conducted electricity, which burned his scalp and his skull, that we eventually found out a few weeks into this. Both hands looked like that, and then everywhere from a thigh, lower leg, where he was in contact with the ladder, there was reverberation of the current back and forth. So there were full thickness injuries in all of those areas. He survived. This is day 2, where he's already gone to the operating room and he had an escharotomy, but immediate fasciotomy of the forearm. And actually, I don't know, is there a laser pointer here? The green one, maybe? Yeah. See the muscle here? That's healthy muscle. Then you get to the zone right here, where all of this is muscle that's basically necrotic. The tendons are still there. He actually still had ulnar flow, radial flow was knocked out, and he could actually move his hand. So we're talking to him about, you need an amputation, and that amputation needs to happen now, right there. It's like, but I can still move my fingers. I want another consult. Can you completely extend them? No. So, is he going to get sick from that muscular injury? Plus, minus? Yeah. What do you think his urine looks like? Looks like dead muscle, which means what? A good red wine. And if you dipstick it, it's gross blood. Yet if you look at it under the microscope, there's no red blood cells, it's myoglobin. So it's dead muscle that's being circulated from there. Burns themselves now, intravascular volume depleted, can have what looks like myoglobinuria, but it is actually hemoglobinuria from red cells that have been lysed that they're excreting in the kidneys. Was he what?
Blind.
Blind?
Right.
His eyes were fine. Yes. And he was a diabetic, juvenile onset, which complicated things as well. But so the answer to this is, if you open it and expose it, and it's not coming up into the biceps with skip areas, then the likelihood of him going on to develop rhabdo that ends up in renal failure, that ends up in dialysis and all of that is pretty low, as long as you keep them aggressively hydrated, which we'll talk about in a little bit. Okay? To keep it up. And then psychologically, these people oftentimes need time to see the deterioration, but more importantly, usually by about the 3rd day, it starts to smell really bad. And it's kind of like you smell that, that's you. Okay? And there's no cure for that other than a major amputation. This is the gentleman I was talking about that didn't know he had blowout injuries on his feet. That's the reason for completely strip them. Examine every part of them. Take a comb and comb through the hair, because it's not uncommon for them to have actually little punctate blowouts in their scalp. And we're not going to treat them any differently other than shave the area, treat it, let it kind of heal in by itself. But from the litigious world in which we live, you don't want to miss an injury and then have to try to defend yourself that we never looked. Why didn't you look? We should have. That's the reason for getting a complete physical exam from head to toe. Now, are we going to do anything with those wounds? Not to start with, because here's the deal. That's the peak of the pyramid. There may very well be deeper destruction underneath it, but we're going to observe these and let Mother Nature do her thing. If they get infected, treat them with antibiotics. If antibiotics aren't working, then you go in. Because here's the deal. You always have a zone of injury and a zone of stasis. The zone of stasis, you will increase oxygen requirements to that tissue if you surgically turn that into another acute wound. So it's not uncommon with electrical injuries that get debrided day 1 to need to be debrided day 2, 3, 4, 5. And every place that you stop, you think you're at viable tissue the next day. It's not viable, not viable, not viable. That's why all the years that I've done this, I found that if they're not getting infected and septic and sick, if you let it demarcate, it will demarcate exactly where it is. And you can take rongeurs, Kelly's, whatever, and just grab that tissue and pull. And it breaks and self-debrides right at what's dead and what's not. And then that area doesn't have the increased oxygen needs to that tissue that it will if you take a knife or a bovie and you burn through it thinking that you're going to cauterize bleeders as you go, because all you've done is create a bigger wound. Chemical burns, alkaline acid. What's worse? Alkaline burn or a chemical burn? Alkaline. Why is that? Usually it's deeper because you're going to get a necrosis of it. It's ongoing, and you can't rinse it off. Once the injury's there, it continues to penetrate. Whereas with an acid burn, the depth of it is typically what it is on inspection. Floor strippers. Okay? Now, why are there different stripes? Saturation longer. This fella was new, worked here, was using the floor strippers to take the wax off with a buffer. Slipped and fell in it, sat in it, and then didn't report it. Just got up and started working again, and then he got home that evening and showered and felt like his butt burned, and then the next morning that's what the butt looked like. So you can just envision where there were folds of the material, and then that's the actual seam where the boxer shorts have an extra piece of fabric there that were sucked in more chemical, and he had more chemical in direct contact there. So bottom line is, don't do your own concrete work, don't do your own bleach work or whatever without reading the labels and wearing the proper protective gear. Okay? So when your wife wants you to put up the fence, guys, and backyard, and you're getting your Quickcrete and mixing it up, why do you think concrete people have those rubber boots all the way up to their knees? Because if that concrete chemical, which is alkaline, gets in your socks, or worse than that, your flip-flops that you're trying to do that with, you'll end up coming to see me in the burn unit the next 2 or 3 days later with a full-thickness burn. Eyes, flush them. Airways, observation, let the edema resolve, and then extubate at that point in time. We always get confused with escharotomies versus fasciotomies, and who needs them, and where do you do them. Okay, what is eschar? Eschar is non-viable tissue, skin. Okay, an escharotomy, otomy just means division of it. So what's a fasciotomy? Division of the fascia. So burns, full thickness, or even deep second, can sometimes lose all the pliability of the skin. And the bigger the burn, the more resuscitation fluid they have going on, the more edema they're going to get. It's like putting on a cylindrical cast that's too tight. So we were going to divide the skin, and typically you have to divide it on 2 sides so that it can have an anterior and posterior leaflet as opposed to cutting it on one side. It may not have enough hinge pliability on the other side to open up. Okay? And a fasciotomy is different. I'll show you some pictures. So this is a little pictogram. And needless to say, the young lady that came in had escharotomies done acutely that night. We do them at bedside. I used a Bovie because it's full thickness injury. Do we have nerve endings still in a full thickness burn eschar? No. So there's no reason to subject him to an anesthetic, tying up a room to do an escharotomy. So there's a division. Chest. If people have a circumferential 3rd-degree burn around their torso, you can oxygenate them, but you can't ventilate them because the chest can't rise and fall. So their oxygen levels are fine, but their CO2s keep going up and up and up. And so what happens? How do you correct hypercapnia? Increase the rate. What happens when you increase the rate in someone who can't ventilate? Oxygen levels go up, CO2 levels go up, 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 and you're thinking it's really confused. So if you make this cut here and here on the chest, you don't have to do anything on the back, but you have to make a sort of a subcostal incision as well to separate the chest from the abdomen. And the minute you do that, the chest rises and falls, and guess what? Peak airway pressures go back to normal, and the next blood gas you get, they're blowing off their CO2. So upper extremities, lower thighs, lower extremities, and we'll carry it down to the foot. There's been no literature to support doing finger escharotomies. There's been no increased salvage rate of digits with finger escharotomies. Once they're burnt, they're burnt. And
is that on the lips?
That's just white teeth. Now, I have had on times, Dr. DeBose, with circumferential neck burns and face burns, carry this all the way up, straight up as if you're doing a neck exploration, because I found that circumferential neck burns, the face is venous congested, and the edema is getting worse and worse, and the minute you make that cut, all of that tends to be less blue from an obstruction of the venous circulation there. Just don't do it over the internal jugular and get into it. So, here's a 96%er who actually had escharotomies, but he also had deeper burns that then on that ended up, and here's the chest. So this guy was suspended in a bucket on an oil well, and the zip line wasn't working, and they had a blowout of the well, and the fire was shooting up to the bird nest where he was, and it took a while for them to get him down. But he survived. So this is an escharotomy that happened, and then it's like, doesn't look good. So ended up doing a fasciotomy, and does this muscle look healthy here? No. When it's brown like that, guess what? So his burn wounds are easy to take care of. How do you take care of those? High AK amputations. There's nothing to do. Skin's burnt, fascia's burnt, muscles burnt, muscles. It's like you can debride all you want. Respiratory care, y'all know all about that. Complications, infections. Electrocution infections are probably more delayed because the deeper tissues take a while for colonization to happen to get to them. But infection's still the number one cause. If a burn survives the resuscitation phase, if they're going to die of an infectious-related problem, either from a pneumonia that you can't cut lungs out to get rid of the infection, or with electrocutions, they may have myositis, necrosis, or develop a necrotizing soft tissue infection that ends up taking the kidneys out, and then with renal failure and pulmonary failure, the multi-organ system domino effect starts to happen. So, how do we prevent burn wound infections? One, you don't burn yourself. That's the best way to prevent it. Outside of that, topicals, and the topical antibiotics do a great job, but for a short period of time. After that, then your body either has to have grown blood supply into it to take care of scavenging pathogens that are invading, and then obviously intravenous antibiotic therapy. But if you have dead tissue, how do we treat dead tissue in the surgical world? Get rid of it. You can deliver all the antibiotics you want to it. You may temporize it and slow it down, but it's going to happen again. So it's an abscess, and I kind of think of burn wounds as abscesses that are waiting to become an abscess. So that's been the major improvement. In 96% are surviving. They come in one day, you resuscitate them, and you're in the operating room within 24 to 36 hours once their volume status is stable enough to tolerate an anesthetic. And you just excise all burn eschar to prevent that first major infectious hit. Silver dressings, are y'all using them on the trauma service now? No, plus minus. I would encourage you to start applying silver to your wounds. They make them now to where even on a Steri-Strip type Band-Aid or whatever, but there's silver underneath it. It is absolutely bactericidal, not just bacteriostatic, and our skin has bacteria on it. So if you're going to put a wound down and you're going to have a little moisture coming up through wound edges, it makes me more comfortable knowing that there's silver in that environment to control the bacteria and kill the bacteria in that area and prevent superficial wound infections that then turn into open wounds that then become fascial exposure.
What about fungus? Is it antimicrobial or your bacterial?
Acticoat, 100% elemental silver, is bactericidal against bacteria, gram-positives, gram-negatives, and fungi.
I'll put it on.
So, put it on. You'll sleep better at night knowing. And then, more importantly, once you do it, you get more comfortable with leaving those bandages on for 4, 5, 6, 7 days as opposed to pulling it off day one. I look at wounds, even with all the feet and toes that I'm cutting off and legs, I put silver on the incision site, and I'll leave a narrow rim of like a small Band-Aid, and then I'll look, and if there's no peripheral edema in that area, there's no superficial wound infection that's sitting there. So leave that on for 3, 4, 5, 6, 7 days. Only if they develop erythema or edema, then you need to take that off and look. And guess what? If you can leave it a week, you take it off, you're almost ready to take staples or stitches out.
We use the silver impregnated gas sponges.
Yes.
So I guess in that scenario.
Yeah, exactly. And prior to KCI getting smart enough to put the silver in the sponges, we were actually taking Acticoat, peeling it apart, and putting one thin layer of all of the elemental silver in the bottom of the wound with the regular sponge on top of it, just to get better colonization control. The alginates, this is my, they have 1% silver in them as opposed to 100% silver. And so they might kill some bacteria that get sucked up into the dressing, but they're not delivering any silver into the wound itself. Everybody knows what you're going to do with that eschar. Cut it off, not the arm, but you're going to debride that down to fascia. And then the erythema is just there because the person waits, because they usually have social circumstances that they don't come in to see you quick enough. Different colors all need to be operated on. What are the complications, particularly with electrocutions? Cardiac. So here's the deal. You get electrocuted, they come in, you get an EKG. If you have a normal EKG, they need to go on a monitored bed. In other words, are they going to develop a potential cardiac problem later? No. Either. It's like cardioverting someone. You either get a good return or you don't. You have an electrocution injury. Now, if they have a block, yeah, they need to be on a monitored bed at that point in time. But if it's absolutely normal sinus rhythm with no abnormalities, that person they don't need to be on a monitored bed, and they may or may not need to even be admitted to the hospital. Originally, when electrocutions were first being taken care of, it's like, well, we need to keep them in a monitored bed at least for 24 hours to make sure that they don't develop some injury from a cardiac standpoint with no skin burns. Not necessary. Electrolytes, obviously you're going to replace. Dr. DeBus and I were having a discussion about hypoalbuminemia and getting the calcium, ionized calcium levels and correction or whatever. I'm a big fan of replacing albumin to keep it at 2.5. Doesn't have to be higher than that, but at least at 2.5, and replacing calcium, magnesium, and phosphorus in your potassium to within normal serum levels, not using the thought process that with a low albumin, calcium is factitiously lower. You add the fudge factor and it would be in the normal range. That fudge factor doesn't have available calcium in circulation to go to the heart in order to maintain normal cardiac activity from that standpoint. Hypoperfusion, any tissue not being perfused, what are you going to get? Elevated lactate. So until you actually resuscitate and you get the vasoconstriction to resolve and them to actually be perfusing all of that tissue out, you're going to potentially have problems with continued elevation of your lactate. And the electrocutions will definitely have that. The myoglobinuria, how do you treat it? Fluid, okay? Here's the deal. Mannitol, anesthesia is still of the nature of the fact that we're going back with these. We want to give them mannitol. Some of them even push other diuretics. Mannitol are probably the safest diuretic therapy to use with that. But you don't do that until you have adequately resuscitated the patient and you have normal perfusion to the kidneys. Okay? It's like giving neosynephrine and vasoconstricting someone who's bled out. You're not going to help the situation. You're only going to make the situation worse. So, as long as they're making more than a cc per kg, even though it's red, they are getting fluid through there. Now, you can alkalinize the urine by giving them sodium bicarb, which alkalinizes the blood, and then it protects the renal tubules from precipitating that cast out in the tubules themselves. That's the reason for adding sodium bicarb to it. But fluid is the answer. Dilution is the solution, same sort of deal. Keep them well hydrated, and then if you want to touch them with mannitol, that's fine. But giving diuretics to people and then having them peak and then they come down, then the next question is, do they need another dose of a diuretic therapy or do they need more fluid? That's why we have doctors and critical care people in that looking at all of them, right? Usually the answer in a young, healthy person is they just need more fluid. Everybody gets tetanus, and then we're going to excise, graft, chop things off, and rehabilitate. And then all the delayed care. So, questions? 12 minutes. None? Bored you to tears? Well, if you don't have at least one question, then I know I didn't cover it all.
I think it's a good the students and the residents attested question that we hear a lot about is the benign leukopenia that you see with facility, correct? I don't know if you can talk about that.
Yeah, here's the deal with that. The young lady that came in, as well as most burns that came in, there is a transient neutropenia with a burn injury that for decades, and it still remains, the answer on the test is associated with Silvadene. The application of Silvadene topicals in large surface areas results in a transient neutropenia. And I believed it when I was his age and her age, and when Acticoat, the elemental silver, came out, it made perfect sense. Every big burn that comes in, we're not going to get this transient neutropenia. We're going to put them in silver, and we're not going to have it. Guess what? Transient neutropenia was still there. And so I really honestly believe that it is a margination of all of the white blood cells that are in our body that are moving into the area, the tissues, out of the vascular space in order to do the job that they're supposed to do, engulfing bacteria. So with that said, how do you treat it? Observation. And do they need antibiotics? Prophylactically? No, not until they get to what I would consider less than 1,000. And once they get to less than 1,000 white blood cells per hour field, then it would probably be wise to start prophylactic antibiotic therapy. Mainly because they have no skin barrier, and then more importantly from that, bacterial translocation in the gut and other areas may come into critical play with that.
And one thing that comes up a lot, we'll get calls from the transfer center sometimes, is somebody with a burn, they don't plan to send it, they want to know, do I treat with antibiotics prophylactically?
No antibiotics prophylactic, because all you're doing is basically you're exposing the bacteria to something that they are rapidly going to become resistant to. So if and when they do get a burn wound infection, that first round of antibiotic therapy that we would have been able to select that are less renal toxic and are less expensive have been taken away. So it's not uncommon for them to be seen in men that are anywhere post-burn day 1, sent to our clinic the second day, and they all have prescriptions for Bactrim, clindamycin, something that they're on. And I tell them, save it for a bad tooth. We don't need to take it for, you don't need to put it on there unless you start developing peri-burn, eschar, erythema. Then we definitely need some systemic care for that. But outside of that, the topical should work initially. Anything else? Well, I appreciate y'all coming. Hope you learned something. Go get lunch.